Hello, my friends. Today we will discuss the routine coagulation tests. My name is Samih Mikhail, and I'm a pathology resident. This is the Pathway channel. Please like and subscribe. In one slide, these are the routine coagulation tests. The prothrombin time, activated partial thromboplastin time, thrombin time, fibrinogen, Ddimer, and anti-factor 10A assay. Let's start by the prothrombin time. The prothrombin time is used to assess deficiencies or inhibitors to extrinsic pathway, which is factor 7, or common pathway, which is factor 10, 5, 2, 1. And here you can find all the factors written in a way that we can memorize. So this is factor 7, which is the extrinsic pathway. And then we have factor 10, 5, 2, and 1, which are the common pathway. I will explain first what happens inside the body and how we try to simulate this outside the body to just calculate the time till the clot will be formed. So inside the body, with any injured tissue cell or endothelial cell injury or monocytes, we have the tissue factor. Tissue factor will combine with factor 7, active factor 7. This complex is called tissue factor 7 active complex, which by turn will start the common pathway activation using calcium and phospholipids. The common pathway will start by inactive factor 10, which will be activated to factor 10, and with the usage of factor 5 active and calcium and phospholipids, prothrombin, which is factor 2 in the inactive form, will be activated into factor 2 active, which is the thrombin, and the thrombin by turn will activate factor 1 from fibrinogen to fibrin clot. And this clot is still soluble, and we will know what will happen next with factor 13. So this is the cascade, extrinsic pathway, and common pathway. Now we need to measure or to determine if we have any deficiencies or inhibitors to this cascade. So let's try to simulate this outside the body. So we will need the prothrombin reagent will contain thromboplastin, which is the tissue factor we have here. Perfect. And we need also calcium and phospholipid. So the reagent, the prothrombin reagent, will contain thromboplastin, calcium, and phospholipid. Then the prothrombin time, or the prothrombin seconds, which we will calculate after adding the reagent to the patient plasma, we will use it to calculate what we call the INR. INR is the International Normalized Ratio, and it was developed to monitor vitamin K antagonist therapy, which is the warfarin. So warfarin is an anticoagulant, and it acts on vitamin K dependent factors. So it competes with vitamin K for the coagulation factors. We have another term we need to memorize, which is the ISI, which is the International Sensitivity Index. And again, this indicates how sensitive the reagent is to deficiencies in vitamin K dependent factors compared to what? Compared to the WHO reference standard. So the INR and the ISI, they are kind of a way to normalize, or not normalize, but standardize the reference range between laboratories, because each lab will use different reagent, and at the end we need to standardize the reference range. So this is the story of the prothrombin time with the extrinsic and the common pathway. You need to remember warfarin in the extrinsic pathway, or the vitamin K dependent factors in the extrinsic pathway. Let's go next to the activated partial thromboplastin time. Why first we call it partial thromboplastin time? Because this reagent does not contain the tissue factor or the thromboplastin. That's why it's partial thromboplastin. And it does not contain also the calcium. Okay, let's first know what happens inside the body. So this is another way where blood can form a clot. It starts by contact factor, which activates factor 12. And factor 12 will activate factor 11. Factor 11 will activate factor 9. And then we have the active factor 8. And we can memorize them like this. We will start by factor 12, end by factor 8, and skip factor 10. Why we skip factor 10? Because factor 10 will be the start of the common pathway. So the intrinsic pathway will be 12, 11, 9, 8. And again here, before we start factor 10 in the common pathway, we need calcium. But here we have a problem. It's not present in the partial thromboplastin reagent. So we will need to add it later. So this is what happens inside the body. Let's try to simulate it outside. So the partial thromboplastin reagent will contain the contact activator, which is the contact factor. And the cascade will start. But it will stop at this station because the reagent does not contain calcium. That's why after warming the plasma and adding the partial thromboplastin reagent, we will add later on calcium and calculate the time needed to form the clot. Again, here, the fibrin clot is a soluble one. It needs factor 13 to be converted to the mesh. Let's go to the thrombin time. And thrombin time here will be much more easier than the other two reagents or the other two tests, because the thrombin time here will act only on the common pathway, so only factor 2 and factor 1. We know that factor 2, the inactive one, is called prothrombin, and then it will be converted to the thrombin factor, which is factor 2 in the active form, and we know how to activate this via the common pathway, via factor 10, factor 5, and all things we mentioned in the previous slides. The factor 2 active form will act on fibrinogen, and it will form the fibrin clot. Again, to memorize thing, I'm keeping on repeating myself. This fibrin clot is the soluble fibrin clot. So the thrombin time will be used to assess deficiencies or dysfunction in the fibrinogen, or the presence of inhibitor to the thrombin. Okay? So the measurement is done by adding thrombin to the patient plasma, and we calculate the time in seconds till the plasma forms the clot, or the clot is formed. Perfect. Let's go to fibrinogen. Here the fibrinogen, the test is used to assess the fibrinogen activity. Let's see how this will happen. First, we need to know two pieces of information. The first one, what are the causes of hypofibrinogen anemia? It can be kind of consumption, like in the DIC. We can lose fibrinogen when we bleed, and maybe due to low production if we have liver disease, or rarely in congenital causes. The second piece of information we need to know is that fibrinogen is an active phase reactant, which can be elevated in any kind of inflammation. So this may give you false impression that you have high fibrinogen level. How do we measure the fibrinogen activity? We get the patient's plasma, dilute it, and warm it, and add the thrombin reagent on it. And then we will calculate the time needed to form the clot. But here, the time is inversely proportionate to fibrinogen activity. The longer the time to clot, the low concentration of fibrinogen in the sample. Let's go to this graph. This is the clotting time in seconds, and this is the fibrinogen level. And these are just, the numbers are just example, okay? So let's say here in this example that we needed like 8 seconds to form the clot. Here, if we draw this line, 8 seconds will correspond to, let's say, 4.5 grams of fibrinogen. Let's say this time will be prolonged. Instead of 8 seconds, it will be, for example, 15 seconds. So we are here now. Let's draw the line. 15 now will correspond to 3. So instead of 4.5, it's now 3 grams per liter. So if time is prolonged, then the level will decrease, and vice versa. If we needed just 5 seconds, then 5 seconds will correspond to fibrinogen level of 6 grams per liter. I hope the idea is clear. You can keep on repeating the video to understand the idea. Let's go to the D-dimer. So let's understand what is the D-dimer first. We have here from the common pathway, the activated factor 2 will be used to activate factor 1, the fibrinogen, to fibrin mesh, which is the soluble one, as I mentioned in the previous slides. Then with factor 13, fibrin mesh, the soluble one, will be converted to the cross-linked fibrin mesh. And then this one with the plasmin, which is previously plasminogen, and it was activated to plasmin, will degrade this one into two things, D-dimer and fibrinogen degradation products. So here we measure the D-dimer. We see whether it's increased or decreased. What are the reasons or causes of increased D-dimer? Trauma, surgery, infections, DIC, tumors, even normal pregnancy and healthy individuals, they may have elevated D-dimer. That's why it's not specific. And it can be used with other tests or algorithm to diagnose diseases. But by itself, it's not specific. And some labs, they use the qualitative form to measure the D-dimer, which is just like kind of positive, negative, or they can use quantitative assays to measure the D-dimer. Last thing, the anti-factor 10 assay. This one is used to measure the activity of an anticoagulant that inhibits factor 10 active form. So how do we do this test? We have the plasma of the patient, which contains his plasma plus the drug he administered. We need to know how much or the effect of this drug on factor 10 assay, on factor 10. So simply, we will add from outside extra factor 10. And this extra factor 10 will combine automatically with the drug in the plasma. Complex will be formed between drug and factor 10 we added. Now, by turn, we will detect the residual factor 10 by chromogenic substrate. And here again, it's inversely proportional. Since we have this line in this direction, so it's inversely proportional. Okay? So let's open the curtains to summarize everything. So we studied in this video 2 cascades, or we can say 3 cascades. If we calculated like the common pathway as a separate one, though we should not do this, it will start, we just have 2 cascades, the intrinsic one and the extrinsic one. Extrinsic one starts by tissue factor and binding with factor 7 active form. Then, so the extrinsic here is represented mainly by factor 7. And then we have the intrinsic. As we mentioned, we can memorize them starting by factor 12, ending by factor 8, skip factor 10. And then we have the common pathway, which starts by factor 10, 5, 2, 1. And then we form the fibrin clot, which is the soluble one. We need factor 13 to form the insoluble fibrin clot. And then by turn, everything should have an end. So by plasmin, we convert the insoluble cross-linked fibrin into fibrinogen degradation products and Ddimer. Thank you so much. Please like and subscribe to the channel.